Hello, everyone. I hope everyone's comfortably entering the room, the webinar that we're going to be starting in just a few moments. I'd like to welcome you all. It's my honor and privilege to be co-moderating a webinar on World Anemia Awareness Day. I'm Linda Shore-Lesserson. I'm the current president of SABM, the Society for the Advancement of Patient Blood Management. And my co-moderator is Dr. Daniela Filipescu, who is the president of the World Federation of Societies of Anesthesiologists. Together, SABM and WFSA, as I will call them for short, have joined on World Anemia Awareness Day, a monumental, momentous day that we all share. The reason for us coming together on this day is that our missions of the two societies are completely aligned with respect to anemia management. The World Federation of Societies of Anesthesiologists and SABM have been fighting for years for the awareness and the treatments of all of the causes of global anemia. So for this reason, we come together today to present a webinar of experts. And I'd like to introduce everyone that you will meet in the next 90 minutes or so, 75 minutes actually. So let me share with you our upcoming agenda. First, I'd like to call your attention to the chat. In the chat, there is the link to the website for World Anemia Awareness. I'd like everyone to join that link, click on it, and if you are on social media, post a few times today so that we can all celebrate our awareness of world anemia and the impending pandemic that it is. The slogan today for the Anemia-thon that's taking place over the 24 hours of February 13th is raise your hands for the awareness of anemia. And I'd like to thank our colleagues at the Human Touch Media Foundation for creating this awareness campaign. So please join in. The QR code that you see on the screen here is the link to World Anemia Awareness website. And the image on the left is our current webinar. So we'll now introduce our webinar participants. As I mentioned, Dr. Daniela Filipescu is a co-moderator of the webinar. She's the current WFSA president, and she is professor of anesthesiology and intensive care medicine at the Carol de Villa University of Medicine and Pharmacy. And she's chief of cardiac anesthesia and critical care divisions at the Emergency Institute of Cardiovascular Diseases in Bucharest, Romania. Dr. Filipescu is also a past president of the European Society of Anesthesiology and Intensive Care. For myself, I am the current president of SABM, the Society for the Advancement of Patient Blood Management. I'm professor of anesthesiology at the Donald and Barbara Zucker School of Medicine, which is in New York, outside of New York City. And I'm a past president of the Society of Cardiovascular Anesthesiologists. Today, we'll be hearing from a number of world-renowned experts. This is the agenda. And I will go through each individual speaker very briefly, and then before their talk, we will have a more formal introduction. At the end of the 4 talks, we'll have a Q&A session, and you can input your questions through that at the Q&A icon of the webinar. So please do submit any questions along the way, but we will be addressing them all at the end of the speakers. And the recording of this Zoom will be published and sent to you via email if you have formally registered for the webinar. So the first speaker will be Dr. Mihai Stefan. And Dr. Stefan is from Bucharest, Romania as well. And he will be speaking about the global burden of iron deficiency and anemia. Following Dr. Stefan, we'll hear from Dr. Jacob Raphael, an anesthesiologist at Thomas Jefferson University, and he will be speaking about how anemia correlates with adverse outcomes in our surgical population. After Dr. Raphael, we will hear from Dr. Margit Kaufman. Dr. Kaufman will be speaking about hospital-acquired anemia or iatrogenic anemia in the critically ill patient. And we will hear from her after that. We will hear from Professor Dr. Pi Zacharowski. And Dr. Zacharowski will be speaking about establishing that patient blood management should be the standard of care, a topic for which he is eminently qualified and expert to speak about. So we welcome you. We welcome you to the next meetings of each of our respective organizations. The WFSA would like you to know about the World Congress of Anesthesiologists in 2026, April 15th through 19th in Marrakesh. And SABM would like you to know about our next annual meeting, which is September 18th through 20th of this year, 2025, in Minneapolis, Minnesota, in the United States. So without further discussion on my part, I will now allow Dr. Daniela to formally welcome our first speaker.
Thank you, Linda. Thank you so much for the wonderful introduction and kind presentations of our event. I'm so honored to co-chair this webinar together with you, and I'm happy to celebrate this World Awareness Anemia Day. Happy World Anemia Awareness Day to all. I'm honored to introduce now the first speaker. Welcome to all our speakers. It's time now to go to the first, who is one of my colleagues, is Dr. Mihai Stefan, who is a consultant in cardiac anesthesia and intensive care, working at the Emergency Institute for Cardiovascular Diseases in Bucharest, and also he's a simulation instructor in the Center of Simulation for Anesthesia and Intensive Care in Bucharest. He's a member of the board of the Romanian Society of Anesthesia Intensive Care and also of the scientific program of the National Congress. He's a diplomate and international examiner for the European Diploma of Anesthesiology and Intensive Care, and he's part of the national initiative group field in the field of patient blood management for the last 10 years, which has led to the implementation of national recommendations through the Romanian Ministry of Health. His research is focused on hemostasis and transfusion, extracorporeal device therapy, education through medical simulation, patient safety, and intensive care medicine. Mihai, you have the floor now, please.
Thank you very much for the kind introduction, and thank you for the invitation to speak today. The theme of my lecture, as already stated, is the global burden of iron deficiency and anemia. These are my conflicts of interest. Today, we will try to learn about how anemia is diagnosed and identified, to explore major causes and risk factors, to identify key patient populations which are affected by anemia, and to understand the global prevalence of anemia and its contribution to the burden of disability worldwide. Anemia is a widespread global health problem associated with poor health outcomes, increased morbidity and mortality, and a substantial health and economic cost. Symptoms of anemia in adults include weakness, fatigue, difficulty concentrating, and challenges with work and activities of daily life. In different populations, anemia has a significant impact. In children, anemia is linked with impaired cognitive and motor development and susceptibility to infections, potentially increasing the risk of mortality during childhood from severe infections such as those due to malaria. Anemia in pregnancy is associated with increased rates of preterm labor, postpartum hemorrhage, low birth weight, stillbirth, and infections for both child and mother. Anemia in older adults is an identified risk factor for hospitalization, poorer surgical outcomes, and increased all-cause mortality. That is why the WHO, the World Health Organization, global nutrition targets for 2025 include a 50% reduction in the prevalence of anemia in women of reproductive age, and, sorry about that, the WHO 2030 Sustainable Development Goals also encompass alleviation of anemia, in particular goal number 2, which states that it should end hunger, achieve food security, and improve nutrition, and goal number 3, which aims for ensuring healthy lives and promoting well-being for all at all ages. Anemia has a complex etiology with multiple possible causes and risk factors. The most common and commonly recognized cause is iron deficiency, which is estimated to contribute to anywhere from about 10% to over 60% of anemia cases, depending on the population group and context. To date, most work on addressing anemia has been focused on the prevention and treatment of iron deficiency. However, other nutritional deficiencies, malaria, and other infections, including parasitic diseases, chronic diseases, inflammation, gynecological and obstetric conditions, and inherited red blood cell disorders, all play important roles in anemia prevalence. These direct causes of anemia are exacerbated by immediate risk factors, underlying risk factors, and fundamental drivers related to broader social inequities. To help member states and their partners in their efforts to make informed decisions on the appropriate tools to support assessing and reducing the global burden of anemia, the WHO has developed a guideline recently published in the year 2024. This document updates and complements previous recommendations published between 1968 and 2005. And in this new guideline, the cutoffs in the definition of anemia have been somewhat changed. They are primarily informed by analyzing data on hemoglobin and other biochemical and clinical indicators, which would enable application of consistent, rigorous criteria to define a healthy individual. This analysis calculated the 5th percentiles of hemoglobin distributions derived from apparently healthy, ethnically diverse populations, predominantly from higher income settings across Australia, China, Europe, North America, and South America. We can observe different cutoffs depending on age, sex, and pregnancy status. For example, we have cutoffs of 105 to 120 grams per liter in children, 120 grams per liter in non-pregnant women, 130 grams per liter in men, and 105 to 110 grams per liter in pregnant women. While these values have been advocated to represent the new standard definition of anemia, there is, however, an ongoing debate whether these are also useful in the perioperative period. Furthermore, this guideline recommends that anemia cutoffs should be adjusted based for elevation of residence and external factors such as smoking. And adjustments provided are to be applied by subtracting the amount recommended from an individual's observed hemoglobin level, or by adding the amount recommended to the existing hemoglobin cutoff defining anemia. The largest study published so far regarding the impact of anemia, and not only anemia but other diseases, is the Global Burden of Disease, Injuries, and Risk Factors study, which was a comprehensive effort to systematically measure the causes and risk factors of death and disability. It presents the most up-to-date and complete estimates of global anemia burden, covering 204 countries and territories, 25 age groups, and male and female sexes from 1990 to 2021. In 2021, the global prevalence of anemia across all ages was 24.3%, a decrease from 28.2% in 1990. The prevalence of severe anemia was 0.9%, moderate anemia was 9.3%, and mild anemia was 14.1%. However, despite a decrease in prevalence, the total number of people with anemia increased from 1.5 billion to 1.92 billion in 2021, a difference which is attributable primarily to the population growth. Furthermore, total anemia years lived with disability, as presented in the right graph, increased from 46.6 million to 52 million, although years lived with disability rate per 100,000 population decreased from 874 to 659 in 2021. Also, in 2021, anemia prevalence varied significantly across different regions. The highest prevalence was observed in Western Sub-Saharan Africa with 47.7%, followed by South Asia with 43%, and Central Sub-Saharan Africa with 35.7%. These regions also had the highest rates of years lived with disability. In contrast, the lowest anemia prevalence in 2021 was recorded in Australasia with 5.7%, Western Europe 6%, and high-income North America 6.8%. Disparities were even more pronounced at the country level. The three countries with the highest anemia burden, which were Mali, Zambia, and Togo, each had a prevalence exceeding 50%. Meanwhile, Iceland, Norway, and Monaco conversely reported the lowest prevalence, all below 5%. Across all ages, males had a lower prevalence of anemia than females. The 2021 all ages prevalence was 17.5% in males and 31.2% in females. Differences by sex were particularly large among adolescents and adults. Whereas children younger than 5 years had a comparatively high anemia prevalence of 41.4%, the differences between males and females were smaller for that age group. Prevalence and years lived with disability in males and females began to increasingly diverge, as seen in the graphs, after age 5 and did not begin to reconverge until age 80. For females aged 15 to 49, the anemia prevalence was 33.7% compared with 11.3% for males. In every region, females had a higher anemia years lived with disability than males. Regions with the largest female-to-male ratio were tropical Latin America, East Asia, and Eastern Europe. Across all ages and sexes, the leading causes of anemia years lived with disability globally were dietary iron deficiency, hemoglobinopathies and hemolytic anemias, and other neglected tropical diseases, collectively accounting for 84.7% of anemia years lived with disability. This burden was particularly large for dietary iron deficiency anemia, comprising 66.2% of total anemia cases, with 444 million cases among males and 825 million cases among females globally in 2021. Dietary iron deficiency was the leading cause of all ages anemia years lived with disability in every global burden of disease super region. There was also significant variation in the relative contribution of causes of anemia by age and sex that mirrored the underlying epidemiology of the causes. For example, in the oldest age groups, to the right of these two graphs, anemia due to chronic kidney disease increased considerably, accounting for the second largest share of anemia years lived with disability globally for people older than 80. Among children younger than 5, the most frequent cause of anemia was dietary iron deficiency, but hemoglobinopathies, other infectious diseases, and malaria were also important contributors in locations where these diseases were prevalent. In general, changes in the epidemiology and prevalence of underlying causes over time were similarly reflected in changes in anemia burden. Gynecological disorders and maternal hemorrhage were important contributors to anemia burden among women of reproductive age, although dietary iron deficiency was the largest contributor for females in this age group and accounted for a substantial portion of the difference in anemia burden between males and females. In conclusion, anemia affected more than 1.9 billion people and caused 52 million years lived with disability in 2021. This massive burden represented 5.7% of all years lived with disability, with only 2 causes responsible for more disability worldwide: those who are low back pain, and depression. There are widespread challenges to using a broader and more inclusive approach to anemia control, and experts and stakeholders propose various ways forward, including improving education and raising awareness about anemia, cultivating national and local collaborations among sectors, strengthening food systems, and promoting innovation for better service delivery. This WHO framework for anemia management proposes strategic, effective, and implementable actions, which by leading to the reduction of anemia will improve health and accelerate progress toward national and global targets. Thank you.
Thank
Thank you
you.
very
Hi.
much. Thank you, Dr. Stefan. It's now my pleasure and honor to introduce a colleague of ours, Dr. Jacob Raphael. Dr. Raphael is professor of anesthesiology at the Thomas Jefferson University Hospital, and he is currently the director of clinical research in the Department of Anesthesiology and Perioperative Medicine. Thomas Jefferson University is in Philadelphia, Pennsylvania, in the United States. Dr. Raphael also serves as the co-chief for patient blood management services throughout the Thomas Jefferson Health System. He completed his medical school in Israel at the Hadassah Medical Center in Jerusalem, and he was a professor of anesthesiology at the University of Virginia before moving to Philadelphia to serve in his current role at Thomas Jefferson University. His clinical practice involves the care of patients undergoing cardiac and thoracic surgical procedures. He has also extensive experience caring for children with congenital heart disease as well. His primary area of interest in research focuses on outcomes after cardiac surgery, optimizing patient blood management, and optimizing end organ outcomes after cardiac surgery. Dr. Raphael is a member of the board of directors of SABM, and he will serve as co-chair of the upcoming annual meeting in September of 2025, the upcoming SABM annual meeting. In addition, he's also served on numerous committees for the Society of Cardiovascular Anesthesiologists. He has chaired the Committee of Continuous Quality Improvement for Blood Management for the SCA, and he is currently on the ASA Committee on Patient Blood Management. So please, without further introduction, welcome Dr. Jacob Raphael.
Hello, everyone. I'm honored and privileged participating in this webinar. I'm very happy to present, and thank you very much, Dr. Filipescu and Dr. Shore-Lesserson, for inviting me and for the kind introduction. In the next 10 or so minutes, I will be speaking about the effects of anemia on surgical outcomes after both cardiac and non-cardiac surgery. Here are my disclosures. And here are the learning objectives for the next few minutes. So what I'm going to be doing is I'm going to be very briefly discuss the epidemiology of preoperative anemia. I will focus on effects of preoperative anemia on postoperative outcomes, both in cardiac as well as non-cardiac surgery. And finally, I will be presenting some guidelines and recommendations that have been developed recently and published recently by various societies and professional organizations. So perioperative anemia is defined by the World Health Organization based on the global definition of anemia, which is hemoglobin less than 13 in men or lower than 12 in non-pregnant women. And as the previous speaker already very nicely presented, there are about 2 billion of cases worldwide of patients suffering from anemia, which represents about 25% of the world population. In surgical patients, somewhere between 25 and 30% of patients present to surgery with anemia. And anemia is the strongest predictor for intraoperative red blood cell transfusion in cases that require transfusion and associated with increased blood loss. And over the last 30 years, there is plenty of data, a very large body of data that has been accumulated showing that both anemia and red cell transfusion are associated with adverse postoperative outcomes. To the right here, you can see a chart that was published by Lepar and colleagues from the University of Virginia, looking retrospectively of more than 33,000 CABG surgeries, showing that patients with preoperative anemia have a higher likelihood of requiring intraoperative red blood cell transfusion. And the lower the preoperative baseline hemoglobin, the higher the risk was for getting an intraoperative red blood cell transfusion. This slide has been already shown by the previous speaker, so I'll very briefly just say that anemia is common in both sexes in all ages, but as already been presented, the prevalence of anemia is higher in females than in males, although there's catch-up, and toward the older ages, males do develop significant incidence of anemia as well, and this is attributed to both nutritional deficiencies, GI losses, as well as anemia that is associated with chronic illness. But the bottom line is that anemia is common throughout all ages and in both sexes. And surgery is obviously a bloody business. So there are surgeries that are associated with very significant blood loss, not just cardiac surgery, also non-cardiac surgeries such as major orthopedic surgeries could be associated with major blood loss. This chart actually shows that with joint replacement surgery, which is major orthopedic surgery, blood loss can be as high as 45% of the total blood volume. And in cardiac surgery, blood loss can be even higher and approach even 50 or 60% of the blood volume. And there's an inverse relationship between the preoperative baseline hemoglobin and the need for blood transfusion, which means that the lower the baseline preoperative hemoglobin, there is a higher risk for patients to require intraoperative allogeneic blood transfusion. So if we look at preoperative anemia in cardiac surgery patients, as I already mentioned, it is defined as a hemoglobin concentration that is lower than 13 in men or lower than 12 in non-pregnant women. Somewhere between 25 and 30% of all surgery patients, and specifically cardiac surgery patients, present to surgery with preoperative anemia. And the likelihood of anemic patients to require blood transfusion is as high as 4 times the non-anemic patients. In addition to that, as you can see to the right, in addition to iron deficiency, which is probably the most common etiology for anemia in surgery patients, there are some additional etiologies that may be actually be described by some of the following speakers, one of which is very important is hospital-acquired anemia, but there's also anemia that is related to chronic illness, such as chronic kidney disease or cancer, and other etiologies which are mostly attributed to nutritional deficiencies. So if we look more specifically in anemia and cardiac surgery, this is a retrospective Canadian study that looked at almost 4,000 patients, and they found that the prevalence of anemia was 22%, and anemia was associated with increased risk for mortality, renal failure, and stroke. In addition to that, they also looked at a composite outcome that was prolonged ventilation, renal failure, myocardial infarction, stroke, and sternal wound infection, and found a very significant association between anemia and these outcomes. And they found that this association existed both for patients who required blood transfusion, as well as patients who did not require blood transfusion. And this is attributed both probably for the severity of anemia, but there is also probably a direct effect of blood transfusion on these outcomes as well. Similarly, this is a meta-analysis that included 22 large observational retrospective studies with almost 45,000 patients. And anemia was associated with increased mortality, acute kidney injury, stroke, infection, and other outcomes. So the impact of anemia on outcomes is very significant in cardiac surgery. And just to show you, this is a relatively recent large retrospective analysis that looked at more than 35,000 cardiac surgery patients in the Dutch National Registry, showing that patients with preoperative anemia have a decreased survival after cardiac surgery up to a year after cardiac surgery. They also looked at several years after cardiac surgery, and they show that there is increased mortality to patients who present to surgery with preoperative anemia. In addition to that, they found that their prevalence of anemia was close to 20%. And they found that anemia was associated with a variety of adverse outcomes. Their primary outcome was 120-day mortality. There was an adjusted odds ratio of 1.7 for anemic patients to suffer from 120-day mortality compared to non-anemic patients. But in addition to that, they found that there were additional outcomes such as 30-day mortality, postoperative myocardial infarction, infections, specifically postoperative pneumonia, renal failure, RBC transfusion, prolonged tracheal intubation, readmissions to the intensive care unit, and reoperations. All of these had higher adjusted odds ratios in anemic patients compared to non-anemic patients. And since anemia is associated with increased likelihood for blood transfusion, I wanted to just say one word about blood transfusion. So this is data from the State of Virginia Cardiac Surgery Quality Initiative. Again, they looked at over 30,000 CABG patients, and they found that red blood cell transfusion was significantly associated with bad outcomes such as mortality, renal failure, and stroke. In this specific analysis, they asked the question, which one is worse? Was it the anemia or the red cell transfusion? They found that at least in the immediate postoperative risk, and red cell transfusion is probably pushing a higher risk profile, but preoperative anemia, as you can see here, was also associated with significant risk for mortality, renal failure, and stroke. Moving forward to discuss anemia and non-cardiac surgery. So this is a large retrospective analysis that was published in Anesthesiology about 15 years ago, a Canadian retrospective cohort of almost 8,000 patients, showing that patients that present for non-cardiac surgery and present with anemia have a higher mortality, and this was true both for women and in men. The risk for mortality was higher in men than in women, but nevertheless, the risk for mortality was significantly higher in anemic patients compared to non-anemic patients. And anemia actually serves as a risk multiplier. So this is a large retrospective study that was published about 15 years ago in The Lancet, looking at almost 230,000 patients coming for non-cardiac surgery and assessing the contribution and the risk for various risk factors into operative mortality, showing that anemia is a multiplier of the risk for operative mortality, in addition to every other risk factor that is listed here. So if a patient has a cardiac disease and their risk for mortality is 3.4 times higher, adding anemia to this equation more than doubles the risk for mortality. And the same goes for lung disease, neurological disease, renal disease, cancer, diabetes, and so forth. So anemia is a multiplier of the risk for mortality, adding to the risk that is already existing by other preoperative comorbidities. And just to summarize that, this is a meta-analysis that was published in 2015, looking at 24 studies, almost 1 million patients, published in the British Journal of Surgery. And they found that preoperative anemia, as you can see here to the left, was associated with significant higher postoperative mortality. But in addition to that, other outcomes that were affected was acute kidney injury, stroke, infection, and interestingly enough, when they looked at myocardial infarction, of course, there were a lower number of studies looked at myocardial infarction, but actually in this meta-analysis, myocardial infarction was not associated with increased risk in anemic patients. However, as I already said, mortality, stroke, renal failure, and infection were all higher in patients with anemia. So this brings us to actually say that the timely preoperative screening, diagnosis, and optimization of anemia may mitigate the morbidities associated with both anemia and RBC transfusion in surgical patients. And one of our next speakers, Dr. Zacharowski, actually published this editorial in the British Journal of Anesthesia saying that non-treatment of preoperative anemia is actually a substandard clinical practice, and that patients coming to surgery should not come to elective surgery with preoperative anemia without proper screening and management, and I cannot agree more than that. So just to summarize, I want to show some recent guidelines that have been published. These are the 2024 American Heart Association, American College of Cardiology guidelines that have been published about 3 months ago in the cardiology literature. And in regard to preoperative anemia, there is a strong recommendation saying that in patients with iron deficiency anemia undergoing elective non-cardiac surgery, preoperative iron therapy, either oral or intravenous, is reasonable to increase hemoglobin and to decrease the risk for blood transfusion. Similarly, these are the most recent European EACTA cardiac surgery guidelines, giving a very strong recommendation to patients coming for cardiac surgery to investigate newly diagnosed patients with anemia and to determine the etiology and to start treatment with anemia. They mostly suggest starting oral supplementation of iron to patients with mild anemia and when there is time to wait before their planned cardiac surgery. However, if the anemia is severe or there's not enough time, IV iron is probably more appropriate than oral supplementation of iron. And in patients with severe anemia, erythropoietin stimulating agents should be added. And at the bottom of this slide, what is very important is to remember that the old practice of treating preoperative anemia with blood transfusion is really not recommended and actually has a grade 3 recommendation, which says that we should not practice this type of practice. So in summary, preoperative anemia is common in surgical patients and is associated with increased morbidity and mortality. Anemia is the strongest predictor of intraoperative allogeneic red cell transfusion. Intraoperative red cell transfusion further contributes to adverse outcomes after surgery, and appropriate treatment of perioperative anemia is strongly recommended by multiple guidelines and is effective in reducing the morbidities associated with both anemia and allogeneic blood transfusion. And my last slide, this has already been shown, but I would encourage all of you to join us in Minneapolis in September for the annual meeting of the Society of Advancement of Patient Blood Management. Thank you so much, and I'm very honored of being here.
Well, thank you very much, Dr. Raphael. That was really comprehensive, what you fit into the previous 12 minutes or so. I want to reiterate to all of our members that if there are any questions for any of the speakers, please use the Q&A function, and we will address as many of those questions as we can at the end of all of the talks. So please use that Q&A function for questions. It's now my privilege to introduce Dr. Margit Kaufman. Dr. Margit Kaufman is a board-certified anesthesiologist and intensivist who specializes in patient blood management. Dr. Kaufman comes to us from Englewood Hospital. This is the hospital where SABM really was initiated. The organization was formed out of a bloodless medicine and surgical community there at Englewood Hospital, and it now serves as the model bloodless center in the country, and really is quite a beacon of education and outcomes and forward-thinking innovation in bloodless medicine. So it stands to reason that those who've trained and worked in that hospital are experts in patient blood management, and Dr. Kaufman is. Dr. Kaufman leads initiatives at Englewood Hospital that improve patient outcomes through evidence-based practices in PBM. She recently developed a mobile app and web-based app that enhanced compliance with blood management metrics, and she's begun to transition to the use of AI to help in our blood management clinical practices. So she is going to present to us the avoidance of hospital-acquired anemia in critically ill patients.
Thank you so much for that wonderful introduction and for inviting me to sit on this wonderful panel with such esteemed colleagues. I'm going to take the time today to speak about avoidance of hospital-acquired anemia in critically ill patients. So why should we care about this? Our colleagues out in Western Australia always are giving us amazing data. In a retrospective review of over 8,000 patients, they were able to show that patients who, looking at their lowest hemoglobin that acquired during that hospitalization, that there was a clear link between anemia and mortality and length of stay. About 45,000 patients in the study, about 56%, had anemia during the admission. And it didn't matter if it was mild, moderate, or severe, they were all independently associated with increased hospital mortality and length of stay. Interesting, length of stay was actually longer for patients who developed anemia during admission compared to those who became anemic on admission. And similar to what Dr. Raphael was speaking to before about red cell transfusion, it didn't help things. It actually was intimately associated with an increased odds of in-hospital mortality. So what steps can we take to avoid or minimize these risks of hospital-acquired anemia? So I'm going to speak on quickly 4 topics today about blood loss, inflammation, nutrition, and hemodilution. So how much blood are we actually taking from our patients? In 2022, Dr. Warner and his colleagues at Mayo Clinic put out this excellent paper to discuss what was actually happening really in hospitals in the US. So they reviewed 1 year of phlebotomy practices in the adult ICUs in a major quaternary care academic medical center, and they included all venous, central venous, and arterial blood collections. And not surprisingly, phlebotomy remained a major source of blood loss in hospital patients, and the location with the highest amount of phlebotomy and rates and volumes are really clearly the ICUs. About 10% of the volume that was withdrawn from the patients was actually wasted. It wasn't sent for testing for other uses. It was just unfortunately just in the garbage. Median lab value draws during the volumes were about 5 mLs per day, or about median lab numbers of draws was about 5 per day, or about 41 in a hospitalization. And the median volume withdrawn was about 29 mLs per day in a on average, about 230 mLs in a length of stay. Remember that a healthy functioning adult bone marrow produces only about 20 mLs of blood a day. And our ICU patients probably do not meet the criteria of healthy. I'm a visual learner, so this might be helpful to some members in the audience. Let's using some nice round numbers. If we're removing about 25 to 30 mLs a day from our ICU patients, an average 15-bed ICU, that's over 11 liters of blood removed in a month from our patients. In a year, that's the removal of 27 adult blood volumes. The former chief of pathology here at Inglewood told me years ago that we throw away gallons of our patients' blood every year from phlebotomy. In residency, I had this wonderful attending, Dr. James Say, and he would always encourage us to find the TSC, the technically simple and effective methods, right? So what are our technically simple and effective methods to reduce the amount of blood that we're taking from patients? Can we order less labs? Can we avoid wasting by using closed systems? Are there any add-on features in our electronic medical records? Can we use smaller tubes? Our national societies agree with these simple, basic concepts of what we should be doing. The Critical Care Societies Collaborative, which is made up of the 4 major critical care societies in the US, they say that routine ICU testing needs to be reduced. In studies of routine ICU daily labs, almost 50% of those results were normal, and 32% remained consecutively normal. So was there a really good clinical reason why those labs were needed? In 3 non-randomized studies, though, of reducing lab draws in the ICU, the teams were able to reduce lab draws, reduce the blood loss, and reduce costs without affecting outcomes. So what are some techniques suggested to reduce unnecessary testing? This concept of just ordering daily labs needs to, we need to remove that from a culture. Really maybe switching more to the daily review of the necessity of labs based on what that individual patient needs. Raising clinician awareness about the impact of unnecessary testing. We're all pretty competitive in our field and we like to be the best. And so maybe individual performance feedback is something else that could happen. The STRATUS trial went to look at what does the role of using low volume tube do to the patient? So does routinely drawing less blood in the test tubes make a difference? So our Canadian colleagues successfully designed a trial to investigate if using these small volume tubes would reduce both anemia and transfusion. The small volume tubes are the same size as regular tubes. They just have less vacuum in them, so they actually just pull less blood out. They work on the same machines and they cost the same. One interesting note, though, during the study, that's when the COVID pandemic struck in the middle of this trial. So in their initial analysis, they decided to exclude all admissions during that pandemic phase, which was about 6,000 patients. And when they looked at the data, there was no significant difference in RBC transfusions or a drop in hemoglobin from using the low volume tubes. But when they included all the patients, so the full 27,000 patients, there was a significant difference in transfusions and less drop in hemoglobin. But the amount of numbers were not massive. They did know there was no detectable harm to the patients, no difference in insufficient specimens. The authors felt that probably on a patient level, there was not going to be a huge difference, but on a larger scale, to reduce the needs of transfusions that a hospital provides, it actually might be more meaningful. This study is actually in line with other papers that showed that these small volume tubes make a difference in prolonged ICU stays, like greater than 18 days. We're all aware that there's always ongoing inflammatory processes occurring in our ICU and hospitalized patients. Fortunately, inflammation and illness affect erythropoietin production and responsiveness. At Englewood, what we are looking for is we're checking reticulocyte percent, and then we calculate the reticulocyte index, and based on that level of anemia, and when we use an index less than 2, which we feel shows us a hyperproliferative state, that's when we start to consider using an ESA if the patient doesn't have other reasons for a hyperproliferative bone marrow, such as like they're severely iron deficient. So what about the use of ESAs in the ICU? So there have been actually several meta-analyses that have evaluated the use of erythropoietin-stimulating agents in critical care patients. This is the largest meta-analysis, and they actually suggested a positive impact of ESA administration on mortality. And it's not so easy to get an improvement on mortality in ICU patients with a relative risk of 0.76. In the studies that did evaluate for thrombotic risk, there was actually no detectable difference. And that's very important because that's what everyone is always very worried about. But there was heterogeneity in the studies that were looking for these side effects. The most common dosing used in the studies was about 40,000 units weekly. And I want to note that there was iron supplementation. So in the recent 2020 guidelines from the French Society of Anesthesia and Intensive Care, for the management of anemia in adult ICU patients, they actually said there was strong agreement, a grade 2+, that recommendation to use an ESA in critically ill anemic patients, and they define that as a hemoglobin less than 10 to 12, or trauma patients in the absence of contraindication. Their contraindication specifically was patients with a history of ischemic cardiovascular disease or venous thromboembolism, and they were making this recommendation to reduce red cell transfusions and decrease mortality. As I mentioned, the ESA studies, many of the patients were repleted with iron, but unfortunately, I actually have less information to present on this area. We know that iron deficiency is very common, but there are not strong studies that show that IV iron, even less for oral iron, makes a huge difference in outcomes for patients who are repleted alone. There are some newer studies that are showing that maybe we need a better way to know when and how much iron to prescribe in our critically ill patients. As well, the benefits seem to occur really when there's a combination therapy of iron and ESAs. So this is a recent 2024 meta-analysis of pharmacotherapy for reducing RBC transfusions in ICU patients. And as you can see, EPO alone and iron alone don't really have a very large risk reduction for transfusions, but in combination, they have a much larger reduction for the role in transfusions. And again, there was no difference in venous thromboembolic events or infection risk. There's really still not enough data yet on the hypoxia-inducible factors or vitamin D. So when's the best time to give iron? We just don't know yet. So critical illness results in these characteristic changes to iron metabolism. Up to 75% of critically ill patients show elevated ferritin, but actually a low serum iron at admission to the ICU in those first 24 hours of critical illness. Patients actually with higher serum iron levels on admission have worse outcomes in terms of mortality. And then the inverse occurs. As recovery begins, patients with low iron levels have worse outcomes. There's concerns about giving supplemental iron during those peak critically ill phases. We're not just because maybe are we going to worsen oxidative stress. There's been some proposed concerns about administering iron, which may be worsen sepsis, bacteremia, but it's actually never been shown in human trials. There's a growing amount of work saying that iron supplementation should be considered in the recovery phase, but defining what the recovery phase is still kind of unknown. Hepcidin is probably seems to be coming out that this might be the best marker for us to track, but this is not a standard acceptable marker that many of us are testing for. So I would say stay tuned. And the last section I want to talk about is IV fluids and hemodilution. I'm sure that many of us has asked this question, is this hemoglobin real? Especially when a patient's received a large amount of fluids. In this model that I'm showing up here of hemoglobin 6.7, these vital signs, this easily could be this CHF patient who's completely overloaded or an extremely dry patient. So what are we looking for? Are we seeing signs of this end organ hypoxia or dysoxia? What are the events leading up to these findings? We know that fluid administration can result in beneficial increase in microvascular flow and perfusion pressure, and then a global increase in oxygen delivery and cellular oxygenation, especially when there's a relative volume deficit, such as like distributive shock and sepsis. But we also know it's going to alter our lab values, and we're going to see this dilutional anemia. I know that not many of us have access to non-invasive continuous hemoglobin monitoring, but the technology is available. And as you can see in these graphs, there is a measurable change in measured non-invasive hemoglobin, which is your red line, when a large IV fluid bolus is given. And there's no detectable ongoing blood loss and no improvement in your PVI with fluid boluses. So use these graphs to show that these transfusion triggers of only looking at numbers actually might lead to unnecessary transfusions if there are no signs of decreased oxygen delivery. In this smaller study, the investigators were able to verify the ability of this continued hemoglobin, non-invasive hemoglobin monitoring to measure hemodilution. The measured hemoglobin dropped in concordance with hemodilution. And these were able to show that there may be potential clinical benefits beyond just the detection of actual bleeding. A decrease in non-invasive hemoglobin, the absence of bleeding in acutely ill patients, may be the only sign of hemodilution. Maybe should prompt an immediate revision to our fluid administration strategy. The real-time identification of hemodilution may also have an important potential impact on the decisions to transfuse blood, especially when people are using these concepts of transfusion triggers and such. I always like to put out something for our audience to think about, what concepts maybe could be coming down the road in the ICU. Is there a role for using cell salvage in the ICU with sterile suction canisters and such, especially now that our cell savers are getting more compact and adorable, actually. And so in conclusion, takeaway points, patients who acquire anemia in the hospital are associated with poor outcomes. Unfortunately, some of these causes are iatrogenic, but there are individual steps that probably by themselves don't have a huge difference, but in combination therapies probably have better cumulative effects. We know we can safely reduce the amount of blood we withdraw. We could probably reduce the amount of labs we're drawing easily. There's a role for ESAs in patients. We need to define better when iron is going to be the most beneficial for our patients, and we can create false anemias with IV fluids.
Thank you, Dr. Kaufman, for the outstanding presentation. I think we'll have some questions at the end and time to answer them. Now I have the great pleasure to introduce the last speaker, Professor Zacharowski. He is well known for the patient blood management champions and ambassadors, but I will take a minute to say a couple of words about Kai. He holds the position of the Ordinarius and is the director of the Department of Anesthesiology, Intensive Care Medicine, and Pain Therapy at the University Hospital in Frankfurt, where he is also practicing since more than 20 years before he was holding the position of professor and chair of the Department of Anesthesiology and Intensive Care at the University of Bristol in UK. He was serving as a president of the European Society of Anesthesiology and Intensive Care for the years 2020 to 2021. His scientific contributions are published in peer-reviewed journals such as Nature Medicine, Lancet, New England Journal of Medicine, and Proceedings of the National Academy of Science. Actually, his list of published works is longer than 600 in the PubMed, and these publications, many of them were awarded with numerous prestigious awards for innovative clinical research, but he was also awarded the Humanitarian Award together with US Presidents Barack Obama and Joe Biden, and the Lafayette Award for Patient Safety. Professor Zacharowski is also a member of the oldest continuously existing Academy of Natural Sciences and Medicine in the world, the Leopoldina. He's serving as editor-in-chief for Current Opinion in Anesthesiology and the Journal of Anesthesia and Intensive Care Medicine, as well as an editorial board member of numerous journals in critical care medicine, emergency medicine, anesthesiology, and he's a CEO of the Lofer Foundation and the founder of PBM Foundation. Kai, you have the floor. Thank you for being with us.
Yes, thank you very much, Daniela. Good evening or good morning, wherever you are now. It's a great pleasure being here. So my task is establishing that PBM should be standard of care. And I would like to start here with my disclosures. And I always saying you can rent me, but you cannot buy me. All what I'm telling you is scientific-based evidence. Right, the WHO, we're waiting for the publication, what you see on the right side, in press. And it's a new implementation guidance to improve the global blood health status. And what is blood health? It encompasses conditions such as anemia, blood loss, and coagulopathy. And we have heard this in from the previous speakers. And if you put the numbers together, it affects over 3 billion people and obviously has a significant economic implication. So what is the answer? Quite simple. It's patient blood management, a patient-centered approach, improving patient outcome. So that includes anemia management, reducing blood loss, and the rational use of blood products. This publication has been discussed by Jacob, and it's just another way I have summarized it. Over 200,000 patients undergoing elective surgery, any kind of surgery, exception no cardiac. And what you can see is if patients were suffering from an anemia with a hemoglobin less than 9, the mortality rate was over 10%. If patients were, these are all elective cases, remember, elective, were suffering from mild anemia, hemoglobin 9 to 12, almost 60,000 patients was 3.52, and no anemia less than 1%. So to summarize this, we can reduce 30-day mortality by a factor of over 13 if we do not allow elective surgery to happen when patients are anemic. And this slide alone should be, I don't want to use the word Bible, but this, every solicitor should know this, and that would force us to make better medicine. Because if patients would know these numbers, they would ask, hey, doctor, can you improve my anemia statement before surgery? The Bill Gates Foundation was almost 10 years ago investigating human healthcare problems. And as you can see, number 4 is iron deficiency anemia. If we take all forms of anemia, that is not only iron deficiency, this is around about 30%, but many other causes like renal anemia, age-related anemia, etc. Suddenly, anemia is the biggest problem of humankind, and estimates 2.5 billion people are suffering from some kind of sort of form of anemia. The next thing I would just briefly would like to introduce is women and men are different. And I hope you agree with me. Women are more clever than us, that's for sure. But they have on other things some little disadvantages. They have a lower body weight on average, a lower blood volume, and a lower hemoglobin concentration. And men on average, obviously, more. And what we also should know, and this is, in my eyes, standard of care, that we know the timeline. What you see on the y-axis is the hemoglobin concentration, 12 if the patient or the females have a hemoglobin of 12 or above, they're non-anemic, men 13. But there are various factors influencing the hemoglobin concentration. So the patient comes to the doctor with a problem, blood being taken, several tests, etc. So the blue arrows indicating a loss of blood, so hemoglobin concentration goes down. At some stage, we are coming into the game, anesthesiology and surgery, and we actually can do the opposite. We can increase the hemoglobin concentration, for example, by treating the very common problem of iron deficiency anemia with IV iron. For those, we could give EPO, and nowadays, quite often, lots of people have a lack of vitamin B12 or folic acid. Then obviously the big day, surgery is associated with blood loss, but we can do something again. We can even use, let's say, cell saver. We can do lots of things to improve the hemoglobin concentration. For this, we need standards. So standard operating procedures, and this is the preoperative anemia management standard. You can see it's a version 5. It's been used by the German Patient Blood Management Network. And the important thing is what you need to know is what is the transfusion probability in your hospital, depending on the surgical intervention. If it's less than 10%, we allow surgery. If it's higher than 10%, we would like to know the iron status. And if there's an iron deficit, it needs to be treated with IV iron. Is there no iron deficit? We would like to have men and women with a good hemoglobin concentration, and that means above 13. Then we allow surgery. If it's less than 13, further diagnostics. So I'll just give you a brief example. What should be standard of care in any hospital worldwide. And I give you the example with the WHO anemia definition. As I told you, men 13, women 12. But men and women are different. So a man here, for example, with a blood volume of 6 liters, and here a lady with 3.5 liters. So the surgeon comes, does a highly successful intervention. Both are bleeding 1.5 liters of blood. The man ends up with a hemoglobin of 9.8, the woman with 6.9. In many countries, this leads to a transfusion. And basically, this is the most common cause for transfusion for women in hospitals. So what can we do? Very simple. You can see it on the right side. We are not allowing women to undergo elective surgery with a hemoglobin less than 13. We call this the Frankfurt anemia definition. Same procedure, blood loss 1.5 liter, and the lady ends up with a hemoglobin of 7.5 and no transfusion. So we need to learn to treat women differently, prepare them differently. So preoperative anemia is associated with a 22% longer hospital stay, a 2-fold increased risk of infection, a 4-fold increased risk of a kidney injury, a 3-fold increased risk of mortality, and a 5-fold increased risk in transfusions. So the impact is there, the data are there, we cannot discuss this anymore. It's substandard of care, and thank you, Jacob, for the statement that we are treating or operating on patients with anemia. We have published a study some years ago with 130,000 patients, And it was an area before patient blood management was introduced. These were 54,000 patients, the 4 university hospitals in Bonn, Frankfurt, Kiel, and Münster. And we did a very simple study protocol. And the intervention was optimizing preoperatively the hemoglobin concentration. We used blood-sparing techniques, and we had a standardized transfusion protocol. And the results were absolutely amazing. We had a 20% reduction in transfusion and a 0.2% reduction in complications. It also saves money, because very often we hear, oh, patient blood management costs money. If you have a patient blood management system in place, it reduces cost. And we have calculated it per 1,000 beds, $1 million per year. In Frankfurt, we're down now by over 50% of transfusing red blood cells. So it is safe, it saves money. And finally, our latest study we just published the end of 2023 is the network study of the German patient blood management group with 1.2 million patients. And again, the same signal, transfusion rate went significantly down. We had less hospital lengths of stay, we had no more complications, and there was no change in mortality. So the data is there, it needs to be implemented. And it also has been incorporated now in the guidelines. These are the European Society of Cardiology guidelines on cardiovascular assessment and management of patients undergoing non-cardiac surgery. And you can see a 1B recommendation is to measure hemoglobin preoperatively, and it's recommended to treat anemia in advance of non-cardiac surgery, which is a 1A recommendation, the highest recommendation we know. And the same thing with using a cell saver, it's a 1A recommendation if the expected blood loss is more than 500 ml. And it's also recommended to use point-of-care diagnostics for guidance of blood component therapy, also a 1A. Ladies and gentlemen, it was a great pleasure. We have to do it now. There's no excuse for no one. We have a responsibility for our patients. Thank you.
Thank you, Kai, for the presentation and very clear, very clear message of this webinar also. Now we have a couple of minutes for Q&A, and I will start with the first question for Mihai. So it was related to the levels you presented from the WHO updated cutoff. So will be the 13, the magic number also for the non-pregnant females for defining of anemia. I think it's about the anemia diagnostic outside the perioperative period.
So thank you for the question. First of all, Dr. Zacharowski's presentation was a very comprehensive explanation why it should be 13 for both women and men. Why the updated definition of the WHO, which is, again, it's 2024, so it's the latest WHO definition, still holds to the 12 grams per deciliter in non-pregnant women, is that, again, they argue that they have calculated the 5th percentile of hemoglobin distribution for non-pregnant healthy women, and in non-surgical healthy non-pregnant women, they argue that still 12 is normal. Those patients are, those people are, because they're not patients, most of them are healthy. So the definition has not changed. But in the perioperative period, I fully agree, and our data says the same from Bucharest, that women with 12 grams fare worse than those with 13. So it definitely should be changed.
Thank you. Linda, would you like to continue?
Sure, thank you very much. We have a couple more questions. I hope we can get to them all. This question, I think it's best for Dr. Raphael or Dr. Zacharowski, anyone. It's a great question. At what time limit before the surgery date, if any, does it become ineffective to use supplementation to prevent, or I assume iron supplementation, to prevent the negative outcomes in non-cardiac operations for preoperative anemia?
So I would say that I don't know if iron supplementation and erythropoietin supplementation becomes ineffective at any time. The ideal time should be as soon as possible and probably about 4 to 6 weeks before surgery. But there's good data coming from cardiac surgery. There's a publication in the Lancet by Donat Spahn from 2019, where they treated with iron, erythropoietin, vitamin B12, and folic acid 1 or 2 days before cardiac surgery, and they showed a reduction in red blood cell transfusion. So even if a patient was missed and we start a few days before surgery, there's still probably some effect that could reduce the risk for blood transfusion.
May I add, from a practical point of view, and any patient has deserved the best preparation for the big day for surgery. And the misses are there. We're even treating it the day before, even on the day of surgery, because we know in the long run, on the ward later on, these patients have a faster recovery of the hemoglobin concentration. And if the patient also saw quite good data available, IV iron even works the day after surgery, not far later, because of the inflammation of the obviously the procedure inhibits then and blocks the proper utilization of iron. But even on the day of surgery or 1 day post-operatively is something what you can do for your patients.
Thank you.
Thank you.
Those are
I-
great questions and super answers, because I had the same question as well. Do you want to take the next one? Dr. Filipescu?
Yes, it's about lactate and tissue perfusion, but it was another one I cannot see. In fact, it was referred to tissue perfusion and also anemia due to dilution. So is serum lactate good to monitor this? I don't know who wants to
I
take
guess I'll grab that one. The challenge is serum lactate's not this perfect marker of tissue oxygenation, but we don't have a perfect marker. This concept of dilutional anemia is actually newer in the literature. There's not a lot talking about it right now. I think we all kind of knew it existed, but I think the studies looking at that are somewhat new. And I personally haven't seen anything about lactate, but maybe some of my colleagues have. But I think it's looking at the whole clinical picture and looking for other signs of end organ hypoxia or dysoxia as a role for transfusion, not just like one number.
Thank you. Thank you.
Thank you very much, Dr. Kaufman. Here's a question. I would say we would put it out to the panel because it probably could differ in different practices. The question is about cutoffs for diagnosing iron deficiency anemia. So are there different cutoffs to differentiate iron deficiency anemia from functional iron deficiency? What is your recommendation? Do you use 30 for iron deficiency, 100 for functional, or how do you manage that differential?
A quick answer. It's a tricky question in a way, because we have to see every patient as an individual, and we have to see, obviously, is there any comorbidities? Is there inflammation around? Is there even a little impairment of the kidney or whatever? It's an individual decision and individual testing, and obviously the whole iron metabolism is quite difficult. But to be fairly honest, if we know a patient undergoes a major surgery where we have a transfusion risk of over 10%, it's always worthwhile to treat the patient, even sometimes if you might over-treat the patient, because the patient will lose iron during the hospital stay.
Thank you.
To add to that, I want to say that again, for me as a cardiac anesthesiologist, it's easier to talk about cardiac surgery, but there's some data showing that in CABG patients, There's a study that was published in the British Journal of Anesthesia actually treating non-anemic patients with randomizing them to receive iron versus placebo. And that study did conclude that the patients who received iron, even though they were non-anemic preoperatively, had a better hemoglobin recovery and less blood transfusions compared to those who received placebo. So I suspect that some of them, even though they were not anemic, they were iron deficient. But as Dr. Zacharowski said, we lose blood, we lose iron. So probably even restoring the storages of iron preoperatively is not a bad idea.
Sure, thank you. And I would emphasize also that in cardiac surgery, what you've just said is absolutely true, because not only do we lose iron and lose blood, but cardiopulmonary bypass and the hemodilution that accompanies that also renders the body iron deficient. Even if it's not noticeable on anemia preoperatively, the cells, the heart, are iron deficient, especially after cardiopulmonary bypass. And that's critically important for myocardial function. You know, I think a lot of these questions in the chat can be very well answered by the sage advice that Dr. Zacharowski just mentioned in the last question. Many of these are really individualizing the patient. What is their other end organ function? And what is their baseline status of comorbidities? So I would thank any of our panelists if you'd like to offer an answer by responding by texting in the chat to some of these very specific patient-oriented questions in the Q&A.
There is one more in the Q&A regarding the cutoffs, and this is interesting. Maybe Mihai can answer to this. If we have to have different cutoffs for example, those living at high altitude, or I would add for smokers, for for people with inflammatory diseases, should we have different cutoffs for defining anemia?
So yeah, thank you for the question. The recent guidelines of the WHO definitely recommend to adjust for elevation and for smoking. For you living at 3,400 feet, you should deduce 0.8 grams from your patient's hemoglobin to adjust for elevation. Now, whether this translates into worse hospital outcomes, we don't really know. I mean, this definition and this deduction is based on the assumption that there is a lower at equilibrium, there is a lower capacity to transport oxygen, right, at higher elevations. But in the OR, you control that. I'm not sure that it translates to the surgical patient. That we don't have data on this.
Thank you.
Thank you very much. Let's take one more question. I think this is something we could all benefit from hearing from an expert from a bloodless medicine and surgery hospital. Dr. Kaufman, do you have any advice for this question? Given the adverse effect of preoperative blood transfusion, how can we proceed for a patient needing emergency surgery with severe preoperative anemia?
So, we still use the same framework that we use for all of our patients. So similarly, dosing IV iron and an ESA, even, right around the time of surgery, because we know it'll make a difference later on. Things such as cell salvage is a huge thing that we do, and it's probably underutilized. And then other aspects of reducing bleeding in the OR itself, such as, use of antifibrinolytics, goal-directed testing for like thromboelastography or and such, to make sure that you're treating any of the coagulopathies to reduce unnecessary blood loss. And then keeping the patient's blood in their body afterwards. So there are all these things, but you can change it even in the acute settings, and that's up. And then it's supporting the patient through their anemic phase. So even in bloodless patients, we're going to reduce the amount of oxygen demand. So does that mean that we're going to keep them sedated, intubated, paralyzed, and stuff, so that we reduce the amount of oxygen content that they require at that point? So it is possible even in emergent settings.
Yeah.
So there are some questions about education, awareness, and how to introduce quality measures. And if you would like to take these questions, I would like to mention that for these specific questions, you should involve the national societies in your endeavor. So we are doing this in Romania because we succeeded to have some national regulations on preoperative anemia screening, and now we are working to introduce this in the accreditations of hospitals as a quality measure. But this is a local measure. For the global population, I think that even there are challenges with the WHO support. Already many organizations as SABM and WFSA are working on implementation of PBM, and I think this kind of actions, of collaborative actions and educational products will help to implement all over the world the principles of blood health and patient blood management.
Thank you for that insight, Dr. Filipescu. And I would refer everyone on this webinar to the societies that have sponsored the webinar. So please contact SABM, info@sabm.org, and contact WFSA. And we have the website all behind Dr. Filipescu's screen. And these organizations offer a multitude of opportunities, workshops, lectures, handwritten handbooks, even apps and items for your mobile device. We're really committed, which is the reason that we have come together to form this webinar on World Anemia Awareness Day. So please keep that in your minds. And I'd like to thank Dr. Filipescu for the partnership of the WFSA with SABM. And I'd like to thank very much our speakers, Dr. Stefan, Dr. Raphael, Dr. Kaufman, and Dr. Zacharowski. This is really an informative webinar, and I'm very excited to have participated.
I also thank all the speakers, and thank you, SABM, for this webinar. Thank you, Linda.
Thank you very much, all.
Thank you.
Thank you. Have a good week. Bye-bye.
Happy World Anemia Awareness Day.
Happy.